Hi, I'm Jeff Klein, editor of RadioGraphics, and today I'm pleased to have with us Dr. Juliana Bueno from the Department of Radiology at the University of Virginia School of Medicine, who is the first author of one of our featured papers in the current September 2018 issue of RadioGraphics. Her paper is entitled Updated Fleischner Society Guidelines for Managing Incidental Pulmonary Nodules, Common Questions and Challenging Scenarios. Dr. Bueno, welcome to our podcast.
Thank you so much, Dr. Klein, for this invitation.
So, Juliana, the Fleischner Society Guidelines for the Management of Incidentally Detected Lung Nodules was revised last year in 2017. Your paper begins with a discussion of the rationale for the update, the first since the original guidelines were published back in Radiology in 2005. What is it about this topic that led you and your colleagues to create this paper and the original education exhibit?
Yeah, so the reality is that the assessment of pulmonary nodules is our daily bread as thoracic imagers, and it's not unique to our subspecialty. I don't think there's one day when we don't have to stop in a specific case and really analyze the factors between, the risk factors of the patient, trying to integrate the imaging findings with the recommendation criteria. So at the times when the guidelines were updated, we had the privilege to be working with Dr. Hubert McMahon, who's the first author of the paper. And we were really thrilled to discuss the integration of these new criteria into the management algorithm. And we quickly realized that the language that was used in the new update and the criteria were going to require a better understanding of nodules from the general radiologists and actually the ordering providers. It not only requires understanding on the morphology, but the growth pattern, the risk factors of those patients, accurate measurements, and they were going to be more demanding. So we saw it really as a good opportunity for us to clarify some common questions that we were having trouble answering ourselves, and also educate our community in radiology, not only thoracic imagers, but different subspecialties, as well as our ordering providers and different specialties who are part of this complex management algorithm of pulmonary nodules.
Great. Well, thank you for that. So, Juliana, the main part of the paper begins with a series of common questions that are related to lung nodule management and assessment that arise in typical daily clinical practice. Mm-hmm. With responses by you and your co-authors, which are all of whom are recognized experts on this particular topic. How did you choose the questions that you posed in this part of the paper?
Yeah, so the first part of the manuscript, really we wanted to make sure that the basic information to start applying the guidelines was clear. And we realized that although this should be basic when you think of pulmonary nodules, there were really common questions on what kind of population of patients the guidelines apply to, what's the way or the best way to provide those measurements and the technical requirements. And one of the most important ones is how do you integrate the risk factors of each patient into that management algorithm? So we saw it as a recipe for success. If we had something clear as basic information, then we were putting out the ingredients for that mix that, the guidelines were giving us that recipe to mix those ingredients. We wanted to make sure that they were clear before then.
Great, thank you. So after reviewing the appropriate patient population for which these guidelines apply, your paper addresses some of the technical parameters and the individual risk factors on which some of the recommendations for management are based. You finish the section by discussing how to measure nodules properly, which is obviously very important in making the appropriate recommendations. Can you review for us the methods to be used to measure solid and subsolid nodules for the purposes of estimating risk and using the guidelines appropriately?
Yeah, sure. I do think that this is one of the most important part of the guidelines, making clear how we all should assess pulmonary nodules and giving those technical specifications on how to measure them properly. Measurements are important because they're allocating the patients in that management algorithm. So from the start, they should be well done. I would say that before the measurements are done, we have to make sure that we are using axial sections, thin thin sections with less than 1.5 millimeters, if, ideally. The guidelines specify the use of a long window, and ideally, if it's available, a high resolution algorithm to perform these sections. And then the other important thing is the threshold changed in this new update. So that measurement, that clear measurements should be well recorded, and they are pretty specific on how to do it. So once we have that clear, the next step would be, what kind of nodule are we dealing with? Are we specifically measuring a pulmonary nodule that's solid, or are we dealing with a part solid nodule? And according to that, then we'll do those measurements. So on the first slide, we're showing how to measure a solid nodule that measures less than 10 millimeters in diameter. And the specification of the guidelines is to use the average long axis dimension and short axis perpendicular dimension. So, and this is the way we calculate this. In this case, we have an 8.3 by 7.1 millimeter solid nodule. The average dimension calculated this way would be 7.7 millimeters, and then we would say this nodule measures, or it's approximated to a whole near millimeter, which would be an 8 millimeter nodule for risk estimation purposes. Now, for solid nodules that are larger than 10 millimeters, they specify the use or the recording both dimensions. So we take the long axis and the short axis, and we record those two in the report. In these cases, we don't use the average dimension. Right. And the third part would be recognizing those lesions that are part solid. And part solid is defined as a lesion that contains a solid component and a ground glass component, or a cystic component. And this applies to both. So in this figure, we're actually measuring a subsolid nodule or a part solid nodule larger than 10 millimeters in diameter. And in this case, the guidelines specify the recording both dimensions, a long axis, short axis, in an axial plane. But then for those part solid lesions that contain a solid component larger than 3 millimeters, we specifically measure the largest dimension of this solid component and report it as well.
Great, thank you. So Juliana, the bulk of the paper presents a series of clinical scenarios that highlight some of the challenges and limitations that are associated with the new guidelines. Let's start with scenario number 4, which addresses the follow-up of single ground glass nodules that are less than 6 millimeters in diameter. Can you review for us what features make a ground glass nodule of this size suspicious, such that it would warrant follow-up in 2 and 4 years?
Yeah. So pure ground glass nodules that are 5 millimeters or less are thought to represent atypical adenomatous hyperplasia. And we know that these lesions are invasive or pre-invasive lesions for lung adenocarcinoma. Since it's known that pure ground glass nodules this size take a long time to grow and develop a solid component, there's not really a specification on how to follow them up, and there's no routine follow-up indication. Although the updated guidelines include this caveat, which is in some cases consider 2 and 4 year follow-up. So we really wonder which are those cases. And I have to say that analyzing the morphologic characteristics of these lesions when they are this low density and this small, it's challenging. I would say that figure 2 in our manuscript illustrates an example of a lesion that is not only spiculated, so spiculation would be one of those morphologic features that would be suspicious and would warrant follow-up, or a lesion that is adjacent to a fissure and distorts that pulmonary fissure. And as you can see in the example, we have a case in 2010, a ground glass nodule adjacent to a left major fissure, and there's a very subtle retraction of that fissure. And then we do a follow-up 2 years later, realizing that the fissure is farther retracted anteriorly and the lesion has started to increase in density. This ended up being an adenocarcinoma in situ. So despite the small size and the challenge in morphologically, characterizing these lesions morphologically, this caveat is important because these are pre-invasive lesions that we should warrant further follow-up in specific cases.
Great, thank you. So now scenario number 5 deals with an 8 millimeter part solid nodule that is stable in overall size, or maybe has decreased in size, but with the solid component enlarging. How do we deal with this? And we'll look at figure 3 in the paper, which illustrates such a case.
Yeah. So I would say the most important learning point when we're assessing part solid nodules would be that morphology trumps size. These lesions are part of a spectrum of adenocarcinoma, since it starts as a ground glass nodule and evolves over time, creating an invasive component that is characterized by increased density. So once we realize that these lesions are persistent, the morphologic changes of those nodules are even more important than the size. So in this case specifically, we illustrate an adenocarcinoma in situ that grows over time into an invasive adenocarcinoma. And this is just an example of that common nonlinear growth of adenocarcinoma. So some part solid nodules, as they start creating that invasive component or developing that invasive component, they may either stay stable in overall size when you measure the subsolid component and the solid component, because they create microatelectases or fibrosis within the nodule. They may even show interval decrease in size in the first follow-ups, and that's just part of the process, but it shouldn't be taken as a reassuring finding. So again, morphology and density are much more important than size at this time when we're just assessing those changes in density that are indicating the progressive development of an invasive component.
Right.
And this is one of those cases.
So, Juliana, the final scenario, which is scenario number 8, addresses the issue of lung cancers that are associated with cystic spaces. Can we review the features of cystic lesions that are concerning and should prompt imaging follow-up? And we'll look at figures 8 and 9 to demonstrate such cases.
Yeah. We were specifically interested in cystic air spaces associated with lung cancer because the guidelines do not include these morphologic features of a lesion as suspicious. They mention it, but there's no follow-up recommendation. And, large retrospective studies have shown that almost 1% of lung cancers present with cystic air spaces, most commonly associated with adenocarcinoma histology. So I would say that there are two main morphologic characteristics, and these are illustrated in these figures. The first one is what is known as cystification of a nodule, which is that development of microcysts in a nodule before it starts developing the solid component. And these microcysts are usually secondary to check valve mechanism or some kind of tumor degeneration, but they are associated with this histology. So it's a morphologic feature that we want to pay attention to and create further follow-up. The second one, which is illustrated in figure 9, is the cystic air space that develops a solid component, and this is usually seen as either asymmetric thickening of the cyst, of the wall of the cyst, or development of a mural nodule. That nodule can be endoluminal or just exophytic in the cystic lesion, and this is the invasive component of those cystic adenocarcinomas usually. So being aware of that, cystic morphology of some lung cancers, although they are only 1%, we see them more frequently now that we're, having much more volume with cross-sectional imaging, and this should be something to be aware of.
Terrific. Well, Dr. Bueno, I want to thank you for taking the time today to discuss your paper on the updated Fleischner Society Guidelines for the Management of Incidentally Detected Nodules on CT, which can be found in the current September 2018 issue of RadioGraphics. Juliana, thanks so much for your time today.
Thank you so much for the opportunity to discuss it with you.